Hello, here is Dr. Al Muhammad. Welcome to this session. Today we are going to explore one of the most common shoulder injuries seen in athletes and active individuals, AC joint instability. By the end of the session, you will have a clear and structured understanding of how to approach AC joint instability in clinical practice. In this video, we will cover the anatomy and biomechanics of the AC joint, walk through the Rockwood classification step by step, discuss the evidence-based decision making for management, including the latest guidelines, and finally, go through rehabilitation protocols for both conservative and surgical cases. AC joint separation. AC joint separation. Here is the AC joint connection between acromion and the distal clavicle. Here is the acromion and the distal clavicle. AC joint separation injury caused by direct fall onto the outer shoulder. It's common in contact sport and account for a significant portion of shoulder girdle trauma. The AC joint is stabilized by two main systems. AC joint ligament. Here is AC joint ligaments. Here, from anterior and posterior view, and crococlavicular ligament, conoid and trapezoid. Okay. AC joint ligament control antero posterior stability, like horizontal stability. Limit the movement of the joint anteriorly and posterior. What's about crococlavicular ligament, conoid and trapezoid? Control vertical stability. Superior and inferior stability. And keep the clavicle suspended from the coracoid. Keep the clavicle suspended from the coracoid. Okay. The last thing, stabilize the AC joint. What's named deltotrapezial fascia. Deltotrapezial fascia, which play a vital role in AC joint stability. Let's go in deep. It covers the AC joint, delto, this fascia, cover the AC joint in yellow color. Here it is differentiated from the flesh of the cadaver. It is a picture for a cadaver. It is differentiated from this flesh. It is in red and the fascia in yellow color. Okay. It covers the AC joint, attaching the clavicle to the acromion. Transmit forces from the deltoid and trapezius, providing dynamic reinforcement. Act as a secondary stabilizer. When it acts as the second stabilizers, when there is AC ligaments are injured, to limit displacement. Okay. In surgery, proper repair of the deltotrapezial fascia is essential to restore stability. Okay, let's go to Rockwood classification. It is named by the American orthopedic surgeon Dr. Charles Rockwood Jr., one of the most prominent orthopedic surgeons of the past century, specializing in shoulder surgery and sports injury. Before Rockwood, there was simple classification for OC joint instability or injuries or dislocation, but Rockwood expanded the concept and described 6 grades of dislocation and instability based on the severity of ligament damage and the clavicular displacement. This made diagnosis clearer and the treatment planning more precise. Type 1. Here is a picture of all types of Rockwood classification. Type 1. AC joint just sprained. AC ligament just sprained. In radiograph, usually normal, with treatment will be conservative. And type 2, here is a torn, partial tear in the AC ligament. But CC, coracoclavicular ligament intact. Or mild sprain. Here is mild clavicular elevation. And treatment will be also conservative. Look at this type and this type. Here is mild clavicular elevation. Okay. Type 3. Both AC and CC ligament torn. Both ligaments torn. Complete tear. Okay. Clavicle elevated 25 relative 25% relative to contralateral side. Management debated. Most cases trial firstly conservative treatment. Surgery in selected patient like athletes, persistent pain, cosmetic concerns. Okay. Type 4. Posterior displacement of the clavicle into trapezius. Operative management is recommended. Okay. Posterior clavicle posteriorly displaced in trapezius, in traps. Type 5. Marked superior displacement more than 100%. CC distance increase with soft tissue stripping. Operative very high displacement more than 100%. Type 6. Inferior displacement, and this is rare, very rare. Inferior displacement of clavicle, and the treatment will be operation. 4 and 5 and 6, operative treatment. Okay. According to European Shoulder Associates Delphi consensus. According to European Shoulder Associate Delphi consensus. According to this consensus, AC joint injuries are classified as acute if they occur within 3 weeks. And after, and chronic if they persist beyond 3 weeks. Okay. For acute high-grade injuries, Rockwood 4, 5, or 6, the preferred treatment is anatomic reconstruction of AC joint. 4 to 6, surgery. They especially favor arthros or arthroscopically assisted technique using suspensory device. Okay. Here is a systemic review, and the evidence shows that type 3 injuries remain controversial. No consistent evidence that surgery is superior to conservative management for all patients. Many patients do well with non-operative treatment, while others, like athletes, heavy labor, patients with severe symptoms, or cosmetic concerns may require surgery. AC joint rehabilitation. Firstly, in if type 1, 2, many type 3 initially. We start with conservative treatment. Then, if it fails, we will go to surgery approach. Phase 0, from 0 to 2 weeks, sling for comfort, pain control, elbow and wrist range of motion, avoid overhead activities. The corner point. Avoid overhead activities in first 2 weeks, okay? From 2 to 6 weeks, progressive range of motion, passive, then assisted, then active, as pain allow, within limits of pain. Scapular control also, isometrics for rotator cuff and deltoids. Phase 2, from 6 to 12 weeks, progressive strengthening with band or light weights, scapulothoracic endurance, restore full range of motion. Return to sport or work, type 1 and 2, 2 to 6 weeks. Type 3, non-operative return, commonly between 6 to 12 weeks, phase 2. Okay. First 6-week post-operative is home program. We start with a sling, like that. Here is brace or sling. Pendulum exercise, Codman exercises, circular movement here, like that. Then shoulder forward elevation but assisted. Okay. Supported shoulder rotation, his elbow rest on table or plinths, and make internal and external rotation. Shoulder internal rotation assisted, like that, with bellow. Walk up exercise active to restore range of motion. Okay. Then we will go to isometric exercises for abduction and adduction. Then we will begin scapular strengthening program in protective range. Like that. She raised her shoulder above toward the seal. Like that, starting position, finish position, and return, and repeat it 3 times. Okay. Main muscles worked here, middle trapezius, serratus anterior. You should feel this exercise in your upper back at your shoulder blade. Begin submaximal internal and external isometric exercise in neutral arm at site at week 5. Week 5. This program according to the latest guidelines. Shoulder internal external rotation, and we will add extension isometric toward the seal here, the wall, sorry. 4 to 6 weeks post-operative, joint mobilization and passive range of motion are necessary. Passive supine elevation, as we mentioned before. Deltoid, it is a quick revision. Deltoid isometrics, modalities as needed, like TENS for pain, ice for edema, and the analgesics also for edema, and increased circulation. Neuromuscular facilitation also for deltoid. And I will summarize the electromodalities by the end of this video. Begin submaximal internal and external isometric exercise in neutral, as we mentioned, at week 5, and continue scapular strengthening. Okay. 6 to 9 weeks post-operative, shoulder forward elevation actively, full range of motion. At week 6 to gain full range of motion, to avoid putting a lot of stresses in the first on AC joint in the first 6 weeks. Okay, then full active shoulder abduction, the same idea. Internal and external rotation for the shoulder, but by Sierra band, like that. Here is starting position, finishing position, and here is external rotation, internal rotation. Cross arm stretch for posterior capsule and also posterior deltoid. You should feel this stretch at the back of your shoulder. Main muscles worked here in this abduction with dumbbells: middle and lower trapezius, infraspinatus and teres minor, and posterior deltoid. Okay, scapular retraction and protraction. Move the scapula towards this side, the other side of the body. Retract the scapula, retract it. Middle trapezius will be most active muscle, middle trapezius. In protraction, serratus anterior will contract concentric. You should feel this exercise in your upper back at your shoulder blade. Okay, and begin isokinetic if it available to use it. Isokinetic program, internal and external rotation of the shoulder, eccentrics, because the eccentric exercise put a little stress in the AC joint, and elbow flexion and extension also with isokinetics. Trapezius strength, hold the dumbbell and move your arm back. Main muscles worked here, middle trapezius and posterior deltoid, supraspinatus, because it initiates the first 15 degree of abduction. You should feel this exercise at the back of your shoulder and upper back. Standing row, hold Sierra band like that and move your elbow backward. Middle and lower trapezius worked here. You should feel this exercise at the back of your shoulder and into your upper back. Scapular retraction, W shape position, like that, W shape position. wall press-ups, pressing exercise, push-up exercises, resistance band extension like that. You hold it and from 90-degree shoulder abduction and back to 0. Okay, not hyperextension. Chest opening with band, chest opening with bands to stretch the pectoralis major and contract it, eccentric contraction. Resistance band wall slides, as we mentioned, aggressive upper extremity exercise, internal, here is a summarization, internal, external isokinetics, velocity spectrum, resistance across the range, velocity spectrum, that means that resistance across the range. Okay, begin plyometric program for overhead athletes like baseball, tennis. Posterior capsule stretching after warm up, cross arm stretch as we mentioned, cross arm stretch, plus 16 weeks post-operative functional exercise, and we will continue in plyometrics. Plyometric exercises like that, push-ups, plank row, he pulled the dumbbell toward his chest like that, flexion and extension, and reciprocal motion between right and left upper limb. Repeat 20 to 30 times on each arm, alternating sides. Okay, and one of the most common plyometric exercises like that, push up on the plinths. When to use, finally we will talk about when to use electrotherapy. In acute phase, 0 to 6 weeks post surgery, control pain and inflammation, protect the surgical site, and maintain joint mobility. That's my goal, our goal. Okay, cryotherapy 15 to 20 minutes 4 to 5 times daily. Neuromuscular stimulation and TENS for pain management, neuromuscular, to train and enhance muscle strength and endurance. In subacute phase between 7 to 12 weeks post-surgery, our goal will be restore range of motion, begin gentle strength, and improve neuromuscular control. After surgery for AC joint separation, acute phase 0 to 6 weeks post-surgery, control pain and inflammation, protect surgical site, and maintain joint mobility. Also, cryotherapy 15 to 20 minutes 4 to 5 times daily. Okay, transcutaneous electrical nerve stimulation may be used for pain management as we mentioned before. Okay, here is summarization of when to use electrotherapy. Subacute phase like preoperative, subacute phase postoperative, 7 to 12 weeks as we mentioned in the bust picture. Post surgery, restoring range of motion and begin gentle strength as we said before. Okay, and we may use ultrasound to promote tissue healing and reduce pain. Thanks everyone, thanks for watching, thank you.